Hi, everyone. I'm Dr. Amy Barnhorst. I am a psychiatrist and the director of the Bullet Points Project, which is a firearm injury prevention curriculum for healthcare providers that is run through the California Firearm Violence Research Center at UC Davis. And I'm going to be presenting today on clinical strategies for firearm injury prevention. If you want to learn more about this topic after this class is over, you can follow the Bullet Points Project or me on Twitter. And let's get started. So our learning objectives today are going to be to identify the risk for firearm-related harm and ways to engage with our patients to reduce that risk. And to understand how to have culturally appropriate and respectful conversations with patients and their family to reduce this risk. And at the end, you'll be able to describe available interventions for patients at risk of firearm-related harm, including safe storage options. First, let's talk a little bit about the epidemiology of firearm violence and firearm injury. This is a public health problem, and this means that there are many complex social and cultural and economic factors that contribute to firearm violence. There are more deaths from firearms each year than motor vehicle crashes, and it is among a leading cause of death, particularly for young Americans. Many of these deaths are preventable if we only had the right policies and interventions in place. And the cost of firearm injury in the United States is upwards of $229 billion a year. There are over 45,000 deaths from firearms. As of the last year we had data in 2020, and that means about 124 deaths per day on average. When you look at how those deaths happen, the vast majority of them are suicides. So we often think of homicides as being the danger that we're concerned about, but suicides comprise well over half of firearm deaths each year, with unintentional injuries actually making up a small percentage of firearm deaths, as well as mass shootings making up a very small number of firearm homicides, even though this is often what garners a lot of media attention and what people express great concerns about. Aside from physical and medical consequences, there are socio-emotional consequences of firearm violence. It can have strong effects on people's education, on their well-being, on economic investment in the communities where people work and live, on people's involvement with the criminal justice system, on cohesion of neighborhoods, whether children are allowed to walk to school, play outside, and connect with others, peers in their community, and also on other aspects of their health, including things like people's willingness to engage in risky substance use and risky sexual behavior. So the consequences of firearm violence in the community can be very far-reaching beyond just the immediate medical consequences of a firearm injury. This graph shows the death rates by age and intent of firearm injury among children and adolescents from 2020. And you can see here that among young people, actually homicide is a larger concern than suicide, although that flips as people get older. Unintentional injuries are a risk, but they're a smaller risk for death. They are a larger risk, as we'll see in a minute, for injury. And the risk of both homicide and suicide after a young person turns around 12 or 13 starts to climb dramatically. The homicide risk does level off eventually. And remembering that that was deaths, but when we talk about non-fatal injuries, the profile is a little bit different. So non-fatal injuries are the majority of those are unintentional, while about 42% are from assaults. You'll notice that the unintentional injuries of people who were attempting suicide or self-harm in the blue piece of the pie are very small, only about 3%. And a lot of that has to do with the fact that 9 in 10 suicide attempts by a firearm are fatal. So very few people actually do survive those attempts. There are over 80,000 emergency room visits a year for non-fatal firearm injuries on average. So what can we do as healthcare providers? What is our role in preventing this public health problem? One of the things we can do is assess risk and talk with patients about risk and access to firearms when it's clinically relevant. And our framework for doing so is something we call the 3 A's. And so the 3 A's involve the approach, assessing risk, and the action. So let's tackle each one of these individually. The clinician's approach has 4 components. It should be informed, meaning you should have information about firearms, why people own them, various ways they can be stored, local policies around firearms, and other educational aspects like that. They should be respectful. So you and your patients may not see eye to eye on your views around firearms, but if we're to help the folks who are most at risk of firearm injury, which are firearm owners themselves, we have to be respectful of people's reasons for ownership and the choices that they've made and work within that. Oftentimes that takes a harm reduction approach, meaning the safest thing in our mind may be to get the firearm completely out of the home. But if that step is not possible, then small steps towards safety, like keeping most of the guns locked up, if not unloaded, would be an improvement over keeping guns loaded and unlocked. And the approach should be individualized for each patient. So depending on who's in the household, what kind of risk exists, what are the reasons for firearm ownership, what kinds of firearms are owned. One thing that's important to know when you approach patients with this mindset is that there are no state or federal statutes prohibiting clinicians from talking to their patients about their access to firearms. This is a common misperception based on an old law that was briefly passed in Florida, even though there was a carve out in the law that said if it was clinically relevant, it was an acceptable conversation to have, but that law was overturned. Some things to keep in mind when you're counseling patients about firearm risk is to always put it in the context of risk. So we're not talking about firearm politics here. We're putting in the context of safety and well-being of the patient and the other people in their household. We want to be aware of our implicit biases around firearms and our perceptions, and be able to use appropriate non-stigmatizing language about firearm ownership and about things like lethal means safety, which we'll talk about in a bit. We also want to be informed about the safest way to store guns. So if we're going to be advising our patients, we want to be able to impart evidence-based and accurate information. And again, to consider a harm reduction approach so that you're making reasonable, tailored recommendations that are realistic for that patient and their situation. It's also important to be informed about the relevant policies in your area, because different states have different laws that may be more stringent than federal laws about what is possible or what is prohibited. So what do patients think about having their clinician talk to them about these things? Well, a majority of patients report that conversations about firearm safety are appropriate in a clinical setting. So when surveyed, 66% of respondents said this, including more than half of gun owning respondents. But when they were asked if it was appropriate when somebody in the home was at increased risk, say of suicide or something else, 90% of people said for suicide, it was appropriate for a clinician to have this conversation. And 84% when there were children or teens in the home. And this is why we recommend a risk-based approach, not necessarily screening every patient we see, because there are a lot of time constraints about their access to firearms, but anybody who's at risk, and we'll talk about the risk next. Special considerations about language for talking to firearm owners is just to recognize again, and this is part of being respectful, that firearm ownership may be a part of a patient's identity. It's more than just a tool to them. It may be something that has very important psychological value. And the conversations are really about reducing access for people at risk. Nearly 2/3 of owners in the United States own for self-protection. But there are ways to safely store firearms within the home and also keep them quickly accessible, and we'll cover that in a minute. So having a firearm at the ready isn't necessarily incompatible with, say, keeping your children safe from your gun. Talking about firearms can be perceived as political, and this is where it's really helpful to keep politics out of the conversation and redirect it towards the shared goal of reducing risk for the health and safety of household members. Language very much matters. So saying things like secure storage or safe storage rather than talking about gun safety, which firearm owners may take to mean more about the handling of the firearm. Rather than saying things like taking away your guns or seizing guns, we talk about reducing access when we're discussing making guns inaccessible to people who are at risk. And emphasizing the temporary and voluntary nature of interventions when we can get guns out of the home in a temporary or voluntary way in a time of crisis, to to help people understand that this is a collaborative effort, again, focused on their health and safety. So here are some examples of ways to start these conversations. Lots of patients I see have guns at home. Sometimes when someone's going through a hard time, they store their guns away from home, like with a friend or at a gun range or a gun store. Is that something that you would be willing to do? The second A is to assess, and this is to assess the risk. There's a few things that go into this. So assessing risk factors, and we'll talk about what some of those are, including if there are no risk factors, but the person has ideation or threats, that itself presents a risk. If they have those risks, we want to assess whether or not they have access to firearms. And we want to assess what their willingness is to engage in their own safety or the safety of the household member at risk in a collaborative way. So there are three different categories of risk. Some demographic groups are at high risk. So for example, older white males have the highest risk of suicide in the United States. This doesn't necessarily mean that every older white male we see is at risk of suicide, but that demographic group has a higher risk than other groups. So we should keep in mind that that risk is elevated. And then there are individual risk factors with people who may not meet a high risk demographic group. Things like prior suicidal ideation or attempts, or in the case of hurting other people, present or prior violence. Even being victimized by violence can increase somebody's risk of perpetrating violence, but certainly a past history of perpetrating violence is one of the best indicators of having a risk of future violence. Substance misuse, particularly alcohol and stimulants, is a risk factor for violence, and alcohol is very much a risk factor for suicide. Serious, poorly controlled mental illness can be a risk factor for both violence and suicide, as can dementia and other cognitive impairments. And abusive partners, when combined with firearms, can also pose a risk of violence against others. And then there's the imminent risk, which is somebody, again, who is making threats, making statements, is having ideations about either hurting themselves or somebody else. So some of the categories that should put on a light bulb in your mind that this patient or someone in their household is risk is that there's a youth in the home. So most firearm suicides and mass shootings by teens are with a family member's gun. This means that this is the gun they got access to from probably their parents in the household because the gun was not locked up or not safely stored or not removed from the house in a time of crisis. Children and teens often have access to firearms in the home more often than parents and caregivers think. And there have been some alarming survey results about this, where the vast majority of parents say, yeah, no, my kid has no idea where we keep the gun. And the kid said, yes, I've in fact handled the gun and I know how to get a hold of it within a few minutes in my house. And only about a third of firearm owners who live with children and teens store all of their guns in the safest way. So again, youth having access to firearms, it can be a risk for, mass shootings, again, which are a very small part of firearm homicides, firearm suicides, and also unintentional injury, particularly with younger children. About 7% of children in the US live in a home with a loaded and unlocked firearm that they could access. Alcohol and firearms are another deadly combination. So one study found that a third of people who completed suicide tested positive for the presence of alcohol. And the people who in that study who used a firearm were more likely to be intoxicated at the time of their death than those who used less lethal means. So there's a correlation between violent suicides and alcohol. And for violence against others, alcohol-related convictions without any kind of violence in them are a strong prediction of future violence. And so there's been talk in some states of actually tying alcohol-related convictions like DUIs to firearm prohibitions because that link is so close. Dementia and firearms are another combination that can be very dangerous. About 35 to 60% of people with dementia live in homes with firearms. And when they have access to firearms, because they can lose some of their judgment capacity, because they can become depressed and suicidal, and also because they can become paranoid and potentially act on their paranoid delusions, it can put both themselves and their family members and caregivers at risk. Experts suggest that conversations about gun access with people who have cognitive impairment or dementia mirror those about driving. So this is an ongoing evaluation of, should you have the car keys? Should you have access to your gun? Let's keep evaluating. Maybe you can do some of these things under supervision for a while, but there may come a point where you're no longer able to safely access your car or your gun. Intimate partner violence is another risk that if that is something you suspect going on in the home, guns can play a very deadly role. Almost 50% of female homicide victims are killed by an intimate partner. And when that partner has access to a firearm, the risk of the person dying goes up by 5 times. Firearms can also be used to coerce, threaten, and otherwise terrorize victims of intimate partner violence. And so even when there's not a physical injury from the gun, they can play a very controlling and dangerous role in intimate partner violence. So those are some of the risk factors that we assess for, and things that should make you think, I need to have a better handle on whether or not there are guns in the milieu here with a patient who has some of these risk factors. And we also will talk about their willingness to collaborate, because some of the actions we can take will be collaborative and voluntary, but there may be situations in which a patient may not be able to collaborate, may not be willing to collaborate, or where the risk is so high that an involuntary emergency action may be the appropriate action. So we'll talk a little bit about 4 different actions that we can take or facilitate, including mental health holds, extreme risk protection orders, temporary transfer, and safe storage. And these are kind of ranked from lower risk safe storage to higher risk extreme risk protection orders. When no one is at imminent risk in the home, safe storage is the appropriate recommendation. And safe storage is never the wrong thing to do at a minimum, but there may be other things you want to talk about on top of that. The safest way to store a firearm in the home is unloaded, locked up using a locking device, and we'll show you what some of those are, separate from the ammunition, which should be locked up elsewhere, and with the keys and combinations inaccessible to children and others at risk. So there are a number of options for safe storage of firearms in the home. And the best option is going to be, again, individualized and tailored for your patient by the type and number of guns they have, why they own them, and what their personal preference is. Lockboxes are one of the easiest and most portable options, and particularly for people who own handguns for self-defense, biometric lockboxes can be a great option, because even though it's not the safest way to store a firearm, a loaded handgun can be stored within a lockbox that can be very quickly accessed with a fingerprint to open if somebody needs it quickly. And these lockboxes are portable. People even have them in their trucks, in their cars. They can take them places. They don't necessarily prevent a firearm from being stolen, but they would prevent somebody who was not an authorized user from accessing the firearm. Gun safes provide another option. They're sort of like bigger lock boxes. They can be bolted to the floor, or even, almost like a room, like a small closet in the household for guns. So they can, if properly done, prevent theft, and they can store a lot more firearms. So they can be more useful for folks who have multiple long guns that they use, for example, for hunting, or that they want to store. Cable locks are a very inexpensive, lightweight, and portable way to keep guns safe. The magazine is removed from the firearm, and then the cable lock is run up through so that nothing can be loaded into it. Cable locks are often given away by gun stores, by health programs, and they're great, except, it does take much more time if you wanted to be able to access your handgun quickly to get the cable lock removed and the magazine back in it. And trigger locks are a similar concept, a very small, lightweight, inexpensive device that blocks the trigger from being pulled, but then again has to be unlocked and removed in order to be able to make the gun usable again. So the types of guns owned, how many of guns owned and stored in the house, what they're owned for, this will inform what kinds of safe storage options you may want to talk about with people in order to keep themselves and their family safe. And these options may vary also with the level of crisis going on in the home. So somebody who has, say, suicidal teenager in the home may really want to put everything in the gun safe and make the combination inaccessible, because that may seem like a harder thing to disable or dismantle than one of the other locks. So in terms of suicide, one of the most effective things we can do to reduce suicide risk is to put time and space between the person who's at risk of suicide and lethal means. And by lethal means, that includes medications that can be lethal in overdose, and firearms, which are the most lethal method of suicide attempts. Safe storage can work for this, but it's really important that the person who is at risk does not have access to the safe or the lockbox or whatever it is that is the method of safe storage. So this can be helpful if the parents own firearms and are worried about their teens. If it's your patient who owns the firearms, your patient who owns the gun safe, and your patient who you're worried about, we may have to find another way to put some time and space between them and lethal means. Temporary transfer of firearms can be one method for doing this. And this is something to talk about with patients who are at a slightly more elevated risk, like maybe they're having, a rough patch in their life, they're drinking more, they just got divorced, they've had some recurrence of their depression, maybe some suicidal thoughts, but not enough to actually qualify for mental health hold. Temporary transfer is when you can transfer firearms from the home to a family member or a friend, somebody else who can hold on to them for a little bit. And the person is willing to collaborate with this to reduce their risk of hurting themselves. Some states require a background check for temporary transfer. California actually has a specific exception from their fairly rigorous background check requirements in the case of a suicidal crisis. So make sure that this is one of those policies that you know about and you're informed about in your own state before you recommend it to other folks to do. And sometimes if family friends or friends are not able to hold on to the guns for a while, temporary voluntary storage may be available at local gun ranges or gun stores or even with some law enforcement agencies. But again, this is one of those things you have to kind of check and know what the local policies and practices are. Sometimes a patient may be at very high risk and not willing or able to collaborate. And in that case, emergency interventions may be necessary to prevent harm. The two emergency interventions we'll talk about are mental health holds if the person needs mental health treatment, and extreme risk protection orders for temporary involuntary removal of their firearms. And these two things, importantly, are not mutually exclusive, because mental health holds don't guarantee that the person will lose access to their firearms, especially ones they already own. And extreme risk protection orders may not guarantee that the person get into any mental health treatment to, say, treat their depression that's making them suicidal, or even treat their delusions that might make them a risk of violence. So it's important to remember that while an emergency mental health hold can be a portal for somebody to get into mental health treatment, which may be one way to reduce some of their risk, it doesn't necessarily guarantee that they won't have continued firearm access. Federal law prohibits somebody who's been committed to a mental institution from owning firearms and from purchasing them in the future. But oftentimes that threshold is not met because that involves a long process of somebody getting into an inpatient bed from probably an emergency room and being committed in court. And that can actually happen days, if not weeks, into their treatment process. Many people don't make it to that milestone. Additionally, that prohibition does nothing about the firearms they may already own and have in their house and be going back to after their discharge. So if you're very concerned about their access to guns, with or without a mental health hold, you may want to also consider an extreme risk protection order. In most states, with the exception of Maryland and Hawaii, healthcare providers can't file these orders, but we can facilitate their filing by either law enforcement or family members who are petitioners in every state. I know I've personally talked to law enforcement on multiple occasions about people that I was concerned about, either risk for mass shootings or for suicide, and worked with them so that they could file an extreme risk protection order and remove this person's access to firearms. These exist in 19 states, and they're under consideration in many other states. So they can be a really effective tool for a civil process to temporarily take someone's firearms out of their possession and store them until the expiration of the order. They don't involve a federal prohibition. It's not a criminal act, so nothing goes on the permanent record, but it is a temporary civil order. It allows family members and police, and again, in some states, clinician, to have someone's guns removed based on a concern for violence or suicide in the near future. This may sound like a surprising piece of legislation to be passed, but they're actually really closely modeled after domestic violence restraining orders, most of which do have a firearm removal prohibition, because again, we talked about how intimate partner violence plus firearms can be a very deadly combo. So they have a very similar process, which we'll talk about in a minute. And as someone who has testified in various states on these bills and helped craft the one here in California, I was a really big fan of this, even though I'm a psychiatrist, that there's no mental health evaluation or mental health history required, because most violence is actually not due to mental illness. And many people who die by suicide have no history of mental illness. So while I am a big fan of getting people into mental health treatment who need it, violence and suicide risk are not necessarily closely tied to a history or even a diagnosis. And the important thing when somebody's at high risk of violence or suicide is not necessarily that they get their mental health diagnosis squared away right now, it's that their access to firearms is very quickly removed. The way these orders work is that law enforcement or family members can petition for the order. And there's two types initially. There's the emergency order that law enforcement can actually get by phone from a judge. So if law enforcement shows up on a call and there's somebody making threats right then and there, and there's a firearm in the mix, they can get immediate order by phone with a judge. The ex parte order is something that family member or law enforcement can petition for. And ex parte means that the respondent, the person against whom the order is filed, doesn't have a chance at that moment to argue their case in court. The judge just approves it based on the petitioner's statement. But then within about 2 weeks in most states, there's a hearing. And in that case, the petitioner gets to come and plead their case in front of the judge. So with the emergency and the ex parte order, firearms are removed from the scene very quickly. After 2 weeks, that person can go before the judge and make an argument that they are in fact not dangerous and have, if the judge decides in their favor, have their firearms returned to them. If the judge deems that they are a danger to themselves or to someone else, they can extend the order from 1 to 5 years after the hearing and have the person not have access to their firearms currently and not be able to purchase new firearms for that period of time while the order is active. So just to recap some of the things we talked about today, firearm violence is very much a public health problem. And we as healthcare clinicians are in a unique position to intervene and do something about this problem. The 3 A's framework can help reduce the risk in the clinical setting. And you can follow those, which are the approach, being informed, respectful, taking a harm reduction approach, assessing patients for risk, for ideation and threats, for willingness to collaborate and for their access to firearms, and acting, taking one of the 4 steps we talked about, whether it's recommending safe storage, recommending temporary transfer, or considering emergency mental health holds or extreme risk protection orders. If you're interested in more information, again, you can follow us at Bullet Points Proj on Twitter. You can follow the Bullet Points Project on Facebook. You can sign up at this email for our Bullet Points newsletter. You can follow the Bullet Points Project on LinkedIn. And you can go to our website at thebulletpointsproject.org. And our website has a whole host of information on various clinical scenarios and what clinicians can do in those scenarios when there's concern for firearms in the mix. We have a number of webinar videos uploaded. We've got some information for medical educators coming up. So it's actually a really great resource for anybody who's interested in firearm violence and firearm injury prevention for clinicians. And again, it's organized by these clinical scenarios in which firearms confer a heightened risk and what you can do about them. So thank you very much. And I hope that you all learned something about this and that you feel empowered to contribute to fighting the firearm violence epidemic we have in this country. And we'll now move on to the question and answer section. Thank you.